You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 432 of the podcast. And in this one, I got on Dr Louise Newson. Louise is a GP and Menopause Specialist and co-founder of Newson Health Menopause and Wellbeing Centre, and author of her new book, The Definitive Guide to the Perimenopause and Menopause. So I got Louise on to talk about hormones and how they can impact us, and especially for women going through perimenopause and menopause. I'd like to thank Catherine for her questions for this episode, and thank you to Anna for helping connect me with Dr. Newson and help make this episode possible. So in it, I ask Louise about her doctor story, hormones and mental health. We talk about PMDD, or premenstrual dysphoric disorder, the different hormones and their roles within mental health, some of the perimenopause and menopause symptoms in relation to mental health, hormone replacement therapy, anxieties around hormone replacement therapy, or HRT for short, other lifestyle factors that may help, teenage hormones, men and hormones, and much, much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. Thank you to Louise for her time. I appreciate it, and her expertise. It's very enlightening for me. Thank you to you guys for listening. As always, it means a lot. And without further ado, here is Dr. Louise Newson. Welcome to the podcast, Louise.
Thank you for inviting me.
Yeah, it's good to have you on. So whenever I get a therapist on, usually I'm interviewing therapists who specialize in OCD. I always ask them kind of why become a therapist and then work with OCD. So in your case, I just want to ask you, why become a medical doctor?
Oh, interesting. It's interesting because obviously I do it because I decided because I wanted to make people feel better. But actually I decided really young. I was probably 5, 6, I decided I want to become a doctor. Now, I'm not from anybody in my family is medical, like nobody that I know, no relatives at all. And even when I was really young, so I must have been 6, 7, I remember playing doctors and nurses with my father, but making him be the nurse. And I was always the doctor. And that was in the 70s, so there weren't as many male nurses then. So it's just something that I've really always wanted to do. I've been interested in science. And then when I was a lower 6th, trying to think about university choices, I decided maybe I should use my academic brain, and I really like maths and physics. So I thought maybe I should be an engineer instead. So I went to different companies and tried to learn more about engineering, but it just didn't interest me. So I think anything in life, any job, it's a privilege if you've got a job that you enjoy. And so, yes, it was definitely the right decision for me. But it was a bit weird because I didn't have any influence. You know, I just decided that that's what I wanted to do from a really early age.
Nice. And obviously you do a lot with hormones now. Yeah. And obviously I'll link to all your websites and everything like that. But why specialize in that, and sort of when did you specialize in that?
Well, again, that's quite interesting because if I'd met you 20 years ago and you'd said to me, Louise, you're going to specialize in female hormones, I would have said, no, really? Why? So wasn't on my long-term game plan. And in fact, when I qualified, I really wanted to do oncology, so cancer medicine. And I did a lot of hospital jobs. I did training. I did a job in cancer medicine. But I just decided that it didn't feel, again, I'm quite I do a lot by intuition. And it didn't quite feel like a job that I would want to do forever. Partly because I'm really interested in the whole person and being very holistic. And anything in medicine, not just with hormones. It's a multi-pronged approach. You can't just do one thing. It's like with OCD, you can't just give someone a treatment and expect everything to work. So I was very interested in the whole person. And also, I really wanted to optimize my career with my life, with being married, lots of other things as well. So I decided to go into general practice 25 years ago. And then I worked part-time to fit in with my family and did a lot of medical writing for 25 years. And I've always enjoyed menopause and hormones, like I have enjoyed treating people with with migraines or raised blood pressure or asthma. It's just one of my portfolio of things that I've always done. But then actually, the more I heard from stories from women who were unable to receive treatment, the more I realized it was such a massive problem. And so I started to get into it more and more. And then I experienced some symptoms which really floored me, which I'm happy to talk about later. And then just keep thinking about the injustice of what's happening and why it's such a problem. So and then the clinic is great, but because I've always had this portfolio career where it's not just one job that I do every day, it's great that I can use all the different skills. So my medical writing's allowed me to do a lot of information. I've developed an app. Obviously, I do a podcast. I'm quite outward facing. I've used myself as a messenger quite a lot. But I'm also quite a basic scientist as well. So I read a lot of academic papers. So there's lots of strands to what I do, which makes it really, really interesting, actually, as well. But it's sort of just happened rather than it being on my sort of trajectory of thinking this is definitely how my career is going to be.
Yeah, that's fascinating. And I want to ask you one very, very broad question now. And then after that, every single question is not mine. I consulted with a woman for this podcast who was going through it, who was Catherine, I should say. She gave me some really good questions. She has OCD and she's going through perimenopause, I believe. And she gave me some great questions. So I just want to give her credit for that. But my question was just very broadly, like, what is the link between mental health and hormones?
There's a huge link that actually has been ignored for, I was going to say many years, but actually centuries as well. We know that when we talk about hormones, or when I talk about hormones here, I'm talking about our three, they're so-called sex hormones, but they're not about sex or gender, actually. So estradiol, progesterone, testosterone. And these are hormones that are produced in our ovaries, but actually they're produced elsewhere in our body, including our brain. So if we forget about ovaries and periods for a minute, we need to be thinking about the role of hormones in our brains, which has been neglected for many, many years. And obviously, we produce them in our brains, but even the hormones that we produce in our ovaries and adrenal glands enter our bloodstream. They go all around our body, including to our brain as well. And so when you realize that, then you realize actually that perimenopause, menopause, but also PMS, PMDD are due to fluctuating or low hormone levels. And we know that there's so much that can impact the brain, but anything that changes can impact the brain as well. And so when you have changing levels of anything, we all know if we're hungry, sugar levels change. It affects our behavior, the way we think, everything else. So, and it's the same with hormones. So actually a lot of women have a worsening experience during the perimenopause and with PMS and PMDD when their hormone levels are really fluctuating rather than the menopause. But if you know and understand the role of those hormones in our brain and how they work, then it's no surprise that when we don't have them or levels are altering, it does really affect our brain. And we know that the majority of symptoms are actually symptoms affecting the brain more than any other organ of the body.
Yeah. Wow. Okay. And with PMDD, if you could just talk about that a bit. So from what I understand, it's sort of that week before the period comes, and then there's real heightened mood-based symptoms. Is that correct?
Yeah. So if we think when people have their menstrual cycle, our hormone levels change, and they change because one of the reasons of us having our periods is so that we can produce an egg and become pregnant. That's how women were designed. And so what happens is our hormone levels, estrogen, progesterone, and testosterone actually build up. And then there's a big peak in the middle of the cycle when the egg is produced, and then the levels decline. And then they go up a tiny bit, and then they really decline to very little. And that's mainly the estrogen and the progesterone. And so every woman, when the day or so before her period, her hormone levels are very, very low. Now, some women, they don't notice at all. Their periods come and go. A lot of women, and it's probably the majority of women, will feel a bit lower, maybe a bit more irritable, a bit cross. They might have sugar cravings. They might not sleep as well, just for that day or two. Then their period comes and they often feel a lot better. And that's because then the hormones start to increase. Now, PMS is premenstrual syndrome. So menstrual is the period, so just before. And some people say, well, it's not just one day, it can be 2 or 3 days. And then PMDD, so premenstrual dysphoric disorder, is just when there's nothing just about it. It's when the symptoms are so much worse. And it's thought to possibly affect around 5% of women, but I think it's actually a lot more. But even if 5%, that's 1 in 20, that's a lot of women struggling. And so the symptoms can vary from psychological symptoms to physical symptoms, or a combination. So people might have extreme agitation, anger. They might be obsessively thinking about things, ruminating. Anxiety might be very crippling. Or they might have palpitations, or they might have muscle or joint pains, or they might have inability to sleep. There's lots and lots of symptoms, but actually the symptoms are exactly the same as the symptoms that occur in the perimenopause and menopause, because it's related to hormones. But what's happened for many years, and even now, we see quite a few women with PMS and PMDD in our clinic. And they've tried nutrition, they've tried antidepressants, they've tried behavioral treatments, but no one's thought about treating the underlying cause, which is related to low hormones. And so often when you replace the missing hormones, often a combination of estrogen, progesterone, sometimes testosterone, people feel a lot better, because all you're doing is topping up. You're not replacing the hormones, you're just topping up what's missing for those few days.
Yeah, that's interesting. Because I remember a lady in my life when I was speaking to her probably a couple of years ago now, that she was on antidepressants and had been for some time, and was probably approaching perimenopause. And she finally got to the women's health clinic on the NHS, and the doctor there kind of made the point, I wasn't there, but what I've been told of, women are around this time are sort of unhappy, maybe depressed at times, and then we just put them on antidepressants without checking hormones or anything like that, when really what they might need is hormones.
And indeed, I mean, I'm embarrassed to admit it, but I will. I used to do that as a general practitioner, because I was taught that if you just give antidepressants, sometimes just for that week or 10 days or whatever, then that will help. And it might help. A lot of people say it doesn't really help, or it makes them just feel a bit numb. But I didn't even think about hormones, because sometimes in medicine, you don't think about the obvious things until someone highlights it to you. And it was about 10 years ago now, I sat in someone's clinic, Professor John Studd in London, and a lady came in for a review appointment, and she'd had really bad PMDD. And she came back to tell him that her life was transformed. She felt amazing. And she said, "Oh, this gel that you've given me is incredible." And after when she'd left, I said to John, "But surely you've given her something else as well." He said, "No, Louise, I've given her some estrogen gel and some testosterone gel." And he said, "She's having regular periods, so I haven't started progesterone yet, because she's producing her own progesterone. And it's only a really low dose. It's lower than the contraceptive pill. And she's only having it for those few days where she's experiencing symptoms." And I said, "God, that's genius. Like, why didn't anyone tell me? Like, it's so obvious. Like, my 13-year-old could understand it, but no one had taught me or shown me." So then I thought, oh, this is awful. And actually, a lot more women want to try hormones than anything else, but a lot of women finding it very difficult to obtain.
Yeah, and on the hormones, I guess because or HRT, I've got some questions on that from Catherine
Mm.
later on. But was that kind of scaremongered a bit, right, in the science? If yeah, was it?
Yes, and it's been the biggest uh well, I use the word injustice again, but it's been the most detrimental thing to women's health ever in the history of whole women's health. Because this study that came out in 2002, it was called the WHI study, the Women's Health Initiative study. On the front page was all HRT causes breast cancer, and people just stopped prescribing it overnight. But there are a couple of things about that study that are really important. Firstly, the HRT in that study was synthetic hormones. It wasn't the natural hormones that we prescribe now. So when I say natural, biochemically, they're exactly the same as the hormones that we produce. Whereas then in the study, the estrogen was made out of pregnant horses' urine, which we don't prescribe now, you'll be pleased to know.
Yeah.
And the progesterone was synthetic, it had been chemically altered. So it doesn't have the sort of lock and key, fitting the receptor, causing a whole load of biochemical, wonderful reactions to keep us healthy. It's very, very different. And also, they were giving that type of HRT to older women, average age 64. So very different to what we do now. But even when you look at that study, and now we've got data from 20 years, of course, since it's been completed, it's still all clear that women who took HRT in the form of estrogen had a lower risk of breast cancer, actually, by about 23%. And women who took estrogen and the synthetic progestogen, even if those showed that there might have been, because it wasn't statistically significant, increased incidence of breast cancer, actually, when they follow those women up, their risk of dying from breast cancer was lower than if they hadn't taken HRT. But, and this is the big but, there were far more benefits because we know that women who take HRT have a lower risk of heart disease and osteoporosis. And heart disease kills more women globally than breast cancer. And osteoporosis affects 1 in 2 women who are over the age of 50. But we also know if we replace the hormones, people feel better, which is not a bad thing. So actually, HRT is very, very safe, but there are different types and there are different doses, and individualizing care is really crucially important. So there are a lot more risks. If you think of antidepressants, long term, and not short term, but long term use increases incidence of osteoporosis, for example, which not many people realize. So anything we do could have risks and could have benefits. And this is where HRT has almost been demonized. Everyone just says, oh no, but I won't have hormones. But actually now we produce these biochemically exactly the same hormones. We prescribe them individually. So if a woman needs more progesterone than estrogen, I can do that. It's not a fixed dose. And there's nothing more natural than the hormones that we produce ourselves that we're just topping up. So we need to change the whole conversation. And certainly in women with PMS and PMDD, it's not really replacement. We're just supporting their hormones. So it's just a bit of hormonal treatment. You know, if you had low iron and I said to you, oh, you've got iron deficiency anemia, you'd say, well, where do I get iron from? Let me just replace that iron. And it's exactly the same. This is just a hormone deficiency.
Yeah, it's a good way to look at it. Almost like a vitamin. Yeah. So I guess I just want to understand the role the individual hormones play in mental health. So is it like with estrogen, progesterone, and testosterone? If each one of those are low, would they all could cause mental health challenges?
Yeah, they absolutely could. Now, we've not got amazing evidence because no one's specifically looked really in detail about the mental health component of each individual hormone. But if you look in a basic physiology, you can see that we've got hormone receptors on all of the cells in our brain. And each hormone also works as a neurotransmitter, so a chemical that's sending a signal from one area of the brain to another, but also interferes with other neurotransmitters. I'm thinking, about OCD is really important when we think about, serotonin, we think about dopamine, think about cortisol, adrenaline, noradrenaline, all the acetylcholine, they all change levels if estradiol, progesterone, and testosterone change as well.
Yeah.
So they do have a really important role, but they often work in balance together. So if someone has problems and they're not fully improving, it often isn't just increasing the dose of one hormone. It's often adding in another hormone and seeing how they work together, because all our hormones are very, as you know, closely intertwined, really. But they all do work quite differently in some ways. Testosterone, this is in my clinical experience, often seems to be quite calming. People who fixate a lot, who worry a lot, who wake at 3 a.m. catastrophizing about things that they wouldn't normally have worried about, sometimes they can improve with estrogen and progesterone, but it's often testosterone that just sort of seems to calm down those thoughts. Not always, but it just in my experience, progesterone can be used in different ways. It can be given orally, or some people insert it vaginally or rectally. When it's taken orally, it can stimulate the GABA receptors, so that can be very calming, can help people sleep as well. Obviously, if you sleep better, you just obviously feel a lot better for lots of reasons. So they can have individual roles as well.
Yeah, that's interesting. And I guess, when you hear the word testosterone, I guess most people would assume that's a male hormone, right?
Yeah. Isn't that interesting? Because it is, it's got testes. Like, we don't have testes, so why would we produce testosterone? But actually, testosterone is the most biologically active hormone that we have as women. And when we're younger, our concentrations of testosterone are higher than the levels of estrogen in our body, and they decline with age. So testosterone deficiency isn't really menopause related. It's more an age related thing. But a lot of testosterone is produced in our ovaries. So if women have ovarian insufficiency, so at an earlier age, so say, for example, they have their ovaries removed or damaged by drugs or radiotherapy, for example, then they're going to become more testosterone deficient quicker. But it is really important. But also, estrogen and progesterone are produced in the male brain too. So, which is something that a lot of men don't realize. And very little research is done into the role of progesterone for men and their mood as well. So it's very interesting.
Yeah, I think it's a good point. I think in the next 10 years, hormones are going to become such a key area of research, or at least hopefully in the realm of mental health. Yeah.
I'd hope so. And I hadn't realized it. So over 10 years ago, when I was, as a GP, seeing women who were menopausal, I usually treated them because they would come in and say, "Oh, Dr. Newson, I'm getting flushes, I'm getting sweats, I've got vaginal dryness," really common symptoms. And they were the main symptoms that I would give HRT for. Now, I mean, we've just done a survey for the publication of my paperback, 6,000 women. So these are women who aren't my patients. We just asked about symptoms. And the commonest symptoms are brain fog, anxiety, memory problems, poor sleep, low mood. Hot flushes is number 12 out of their, the commonest symptoms. They're all ones affecting the brain. And a lot of women now I see in my clinic have either a psychiatric diagnosis or they've got psychological symptoms. Most of them have been offered or given antidepressants. Many come from psychiatrists where they've been given lithium, quetiapine. Some of them have had ECT, a few of them have had ketamine infusions, but no one has thought about hormones. And so when you were asking earlier about, is it a brain condition? Well, yes, it affects the brain more than it affects any other organ of our body. So why are psychiatrists and neurologists not thinking about it? And that's really important. And if that narrative can change, that's going to unlock a lot and really help future this conversation.
Oh, yeah, 100%. It's an area that needs to be considered and included. So just looking at my questions here. You've talked about HRT, hormone replacement therapy, but just anything else you want to say on how it can be useful
Yeah, I think what's interesting is that, and difficult too, is that there's no diagnostic test for PMS, PMDD, perimenopause, or menopause. So if I thought, for example, I had an underactive thyroid gland, or if I thought I had diabetes, I could go to a medical person, have a blood test, and they would say, yes, you have, or no, you haven't. With perimenopause, menopause, PMS, PMDD, there isn't a set test, so you can't just do a blood test and be told. But even the questionnaires are really varied and everyone's different. So it's really important, actually. That's why it's so important to have the right knowledge, because then with the right knowledge, often women can make the diagnosis themselves. But then thinking about hormone replacement, often I will say to women, I don't know how much of your psychological symptoms will improve with hormones, or if you've got OCD, I don't know how much is going to improve. But I do know that I can rebalance your hormones in a physiological way, and then let's see what's left. And then I often find once they've got the right dose and type of hormones, and it can take 3-6 months, it can sometimes take longer, then they actually, what else is left. And so then if they are having other psychological symptoms or physical symptoms, those can be addressed a lot easier. But people don't have to have a certain number of symptoms or have symptoms for a certain length of time before trying HRT. And that's really important for people to realize.
Yeah, absolutely. And I think it's good that you're not coming in here and saying, if you do HRT or your OCD is going to be cured or anything like that. You're just saying, if there's an issue, let's treat it and then see what's left.
Yeah. And that's what we do in anything in medicine. And I think that's really crucially important, because I see a lot of women who've got OCD or other conditions, and they're trying everything and they've done so well, but no one's discussed hormones. And that's often the missing piece of the jigsaw. It's not the only piece that's going to transform them, but without it, it's like trying to just run your car without oil. It's going to splutter, it's not going to work properly. And we have to remember that these hormones are biologically active in our brain. They help every cell to function. They help other areas of the brain to function. And so once you understand how they work naturally and normally in the brain, it's a lot easier to understand the role of why you're having them back. Because the natural hormones, it's not the same as me giving someone an SSRI, for example, or a beta blocker. Those are synthetic chemicals that they're just acting on certain areas in the body. These are just literally topping up what's missing.
Yeah. And do you know of any of the free hormones that are maybe more prevalent in OCD that you see with your patients?
No, because studies haven't been done. That's what's really frustrating, isn't it? But certainly I do see a lot of women who have had OCD for a long period of time that's got worse when they've become perimenopausal or menopausal. And often when you strip it back to people, they often have had PMS or PMDD. Or what's really becoming more transparent now, I think, when I really ask, is a lot of women who start contraception find that their OCD has worsened. So I see a lot of women who tell me that when they were on the combined contraceptive pill, their mood worsened, their OCD worsened. And as you might know, when people are on the combination contraceptive pill, which is synthetic hormones, they don't have the same biologically active properties. They often increase something called our sex hormone binding globulin, which then reduces testosterone that's freely available in the body. So if when I took the pill when I was younger, it would have blocked my natural testosterone, and therefore any symptoms that might have not been a problem then could be unmasked, or the contraceptive implants or the progesterone only pill again can switch off the hormones. So it's important to really think, is there anything else that could have upset my hormones in some shape or form? And often once women have the information, they can work it out and sort of piece it together.
Yeah, okay, that's interesting. And so I guess any of my female listeners listening who may be towards perimenopause or fully in menopause, is menopause when you haven't had a period for a year? Is that?
So yes, it's interesting, isn't it? So the definition of menopause is periods have stopped for at least a year.
Okay.
And I find that definition should just be put in the bin, really, because in medicine, why would I say to someone, come back in a year's time and I'll give you a diagnosis? And what happens to us really after a year? Like our menopause is more than just what happens to our womb or our ovaries. And so we need to be redefining it really and thinking about our hormonal changes, because actually sometimes people are a lot better when they're menopausal because their hormone levels are low and they stay low and the body can adjust sometimes. And there's thought that you can get some brain remodeling going on. But in the perimenopause, when you've got this state of flux, hormone levels can be high or low. That can be worse. And we know that, for example, suicide rate increases by a factor of 7 in the late 40s, and it's higher during the perimenopause than menopause. And so we can't, that's where we shouldn't, perimenopause is when hormone levels start changing, but people still have periods. But because they're still having periods, they often don't realize it's related to their hormones. But what we don't want to do is wait for these women, and perimenopause can last 10 years or so. And then you wait a year and then your period stops. And then you go, oh, yes, I'm menopause. Oh, that's why I had such an awful time. And so many people who come to our clinic are living in regret almost, because they're saying, if I'd known what I know now 10 years ago or 20 years ago or 5 years ago, I wouldn't have had to suffer in this way.
Yeah.
And that's what is, I find really sad, that no other area of medicine you allow people to suffer and then treat them. You try and prevent and reduce suffering.
And not to get political or political in a gender way, but do you think that maybe has medicine been a male-dominated field? Maybe that's why this has been neglected?
Yeah, well, it has. I mean, the history of medicine, obviously, they didn't have female doctors for many years, and certainly didn't have female surgeons for a long time.
Or researchers.
And actually, research has never been done. It's always been done on a 70-kilogram man. Women were too complicated to include in research. So we've been neglected as women for research. Female doctors have been put on the back burner a bit, but also I think no one's really owned this space properly. So if you look now at menopause specialists, most of them are gynecologists. Now, if you look at gynecologists, they study and help treat women who have diseases of the ovaries, the womb, the fallopian tubes, the cervix, the vagina, the vulva. We're talking about the brain here. They don't have any brain training. Whereas as a GP, we've had training in lots of different areas as well. And actually, as a physician, I did a lot of training in neurology and psychiatry, but no one taught me about hormones. So there's a mismatch in training here, and medicine now has become a lot more siloed. So if I go to a cardiologist with my palpitations, or if I go to a neurologist with my migraines, or if I go to a urologist with my cystitis and urinary tract infections, or a gastroenterologist with irritable bowel type symptoms, I'm going to have 4 different diagnoses and probably 4 different treatments. But actually, I haven't had that light bulb moment to go, yeah, it's my hormones. And my doctor hasn't, because I haven't been trained. So and everyone just thinks, oh, menopause. Oh, that's a bit boring. But actually, it's not, because you can transform women's lives and keep them healthier and reduce risk of diseases. Because as I've said, people who take HRT have a lower risk of heart disease, osteoporosis, diabetes, probably dementia as well. So it's not just like helping women feel a little bit better. It can really make a huge difference.
Yeah, that's really interesting, and so is the history. So any of my female listeners who are around that sort of age of perimenopause, or maybe starting to, and maybe they've noticed their OCD symptoms have got worse, is that maybe a telltale sign potentially they should go get hormone levels checked out, at least as a backup?
Well, you can't get your hormone levels checked. That's a problem.
Oh, okay.
Because they can really fluctuate. And so although you can buy all sorts of hormone blood tests or saliva tests or even urine tests over the internet or over the counter, they're not reliable. Okay. So it's usually the diagnosis is done on history taking. And it's a bit like OCD, for example. There's no blood test for OCD. It's done on pattern recognition. And often, actually, when the patient has the information, that's when people go, Yes, of course I've got OCD, and it's impacting me on this way. This is the type of treatment or not treatment or whatever or lifestyle or whatever that I'd like to try. And it's the same with hormonal changes. Often when people have information, then they go, oh yes, that's very similar to how I feel just before my period. So it must be hormonally related. Hormone levels can sometimes, we often do them when people are on HRT to make sure they're absorbing, because we use estrogen and testosterone through the skin. Now, the skin is obviously a barrier. It's not meant to have drugs put through it. And some people find their skin is thicker than others, or their blood supply through the skin isn't the same. The way they absorb and metabolize the drug is different. So if someone's on hormones, for example, and they're not feeling much better, then I would usually do a blood test then to see, are they absorbing the hormones? Because if their blood level's still low, then it means that we can change the dose and optimize it. If blood tests that someone does just randomly are low, it can be quite useful. But because our hormone levels can fluctuate, especially in the perimenopause, you might have a normal blood test and then your doctor says, oh, no, it's not your hormones. Well, that split second that you had your blood test taken, it wasn't your hormones. But 10 minutes later or 5 minutes earlier, your hormone levels could have looked very different. So that's why you just have to be careful with blood tests.
Yeah, okay. That makes a lot of sense. I didn't know that. Are there any mental health medications that shouldn't be taken with HRT?
No, so because the HRT that we usually prescribe, so if it's given as the natural, biochemically the same, body identical hormones, then there's no medication you can't take with it, because our own hormones aren't designed to interfere. What is interesting though is that there is some work that shows that women who take antidepressants, including SSRIs, actually, if they've got estrogen in their body, they respond better. So the SSRIs work better. And so that's either because they're having periods and producing estrogen, or they're on HRT. And that's really important, actually, because we see a lot of women who are on SSRIs and no one's offered them HRT. But if there are women who are clinically depressed, who need SSRIs and are menopausal, but you can treat them in parallel. And if you give estrogen with their SSRI, then their SSRI is more likely to be beneficial. So we see a lot of women who basically their SSRI dose is increased and increased and increased. But actually, their dose could probably stay the same if they added an estrogen, because it can amplify the effect. And I've already said at the beginning that estradiol can improve serotonin levels because these hormones all work together. So it's no surprise that it works, but often, I still find it very hard to meet a psychiatrist who prescribes HRT. So that can be very difficult and challenging.
Yeah. I'm sure psychiatry will change, but maybe it's going to be a little slow. So Catherine's asked here, so what is the recommended alternative for HRT for women unable to take HRT, if that is a thing? And then she's also put, or women whose OCD or health anxiety is blocking them from taking it. So there's going to be, sometimes with SSRIs, people with OCD are deeply afraid of taking it. Yes. Because what happens if it hurts me, damages me, changes my brain? Yeah. So I imagine that's the same at HRT.
Yeah, and that's really good questions, because there's a few things to unpick there, really. Some women have been told they can't take HRT, but that's not always for the right reasons. So they might not be able to take the old types of hormones, but the natural hormones are different. So, for example, someone might be told that if they've had a clot before, they can't have HRT because of the risk of clot. Well, the natural HRT doesn't increase the risk of clot. The big group of women where there's less good evidence are women who've had breast cancer before, and that's very individualized. And some women do choose to take HRT who've had breast cancer in the past for the benefits it provides. But there are a lot of unfounded fears still about HRT, and the problem is also in the packaging. So when I open my patches of estrogen, in the insert, it will tell me there's a risk of heart disease, breast cancer, clot, stroke, earlier death, all these things. If I read that, my goodness, I would never use it. But actually, it's not based on research, and it's focusing on the older types of hormones, but they haven't updated it or changed it. And so we do see people with OCD and without OCD, who look at the insert and go, no, I'm not taking that at all.
Yeah.
And so that's where having the right information is really, really crucial, and understanding what is actually in that HRT, because there's lots of people who do have health anxiety, and health anxiety can worsen during the perimenopause and menopause without your hormones. So it's like everything's fighting against these poor people. So if you know, look, actually, I'm just topping up. It's really low dose. It's lower than the contraceptive pill dose. It's looking down the microscope exactly the same as the hormones that you have had in your body for many years. And also you are in control as a patient. So certainly often if people do have huge health anxiety, I will start with the gel, which you just rub in, because you can change the amount you give. So women can start literally, and I've had women start with like 1/8 of the dose, really small, which is not going to make really any difference to how they feel, but it gives them the confidence. And often we can do it really, really slowly. The other thing for people to know is that hormones don't build up in the body. You don't become immune to them, that you need to keep using higher doses. The half-life in the body is quite short. So if I used a very small dose today and then decided that I didn't want to have it again, tomorrow it will be out of my system. And again, it's not, because obviously with SSRIs, there can be more difficulty coming off them. There's all sorts of things, as you know, whereas this is quite different. So working with someone who really understands that it's not like, here, have this now and come back in 3 months' time. And I spend a lot of time, especially with patients who've got OCD or health anxiety, to really help them and give them a lot of support. And sometimes I'd get my team to support and phone and make sure they're okay, you know, just to hold their hand a bit, because it's also like I see so many women now who have health anxiety or feel awful. But then 3 months after, if you can get them through the first 3 months, then they come back and go, oh, I'm so pleased I persevered, because actually it's so much easier. I can think clearer, I can sleep better. My OCD traits have really reduced. I wish I'd done it before, and I don't know why I was so anxious. Well, I know why you were so anxious, because you didn't have those hormones in your body. But it's a chicken and egg thing, isn't it? So you know, but it's making sure that they know that they're in control is the most important thing, that I'm not going around and injecting them with a hormone that's going to be in their body for 3 months. It's literally very, very low dose, and they are doing it. And if they have enough hand-holding initially, knowing what they're doing is safe, then once their brain starts to calm down a bit and they feel clearer, then they're a lot more empowered to make the right decisions. So it's often that first 3 months can be, and I've had literally patients that have come to me over the last few years and they still haven't started because they're so worried. And then they finally do, and they say, I wish you'd persuaded me more before. And I'm like, oh, I have tried, but it's like anything in life. You've got to do it at your own pace, and we're all different. But if people are wondering or they're worried, just try and get more information in a way that you understand. And, you know, I've spent a lot of years providing information that's either audible, or you can read it, or you can listen to it, or you can watch it. Because then I think once you've got knowledge and understanding why you're doing it, it then makes it a lot easier too.
Yeah, I agree. Yeah, that education is so important. And
but the other thing, sorry to interrupt, is that once you've made the decision, I spend a lot of time with patients saying, switch off social media, don't go on any forums, because if people have a health anxiety, it can be very common to ask Dr. Google or go on Facebook groups. And you have to remember that it's usually people that have had negative experiences will write about it, because those of us that feel good on our HRT are too busy with our jobs or our life to go and write a bad review about something.
That's true.
So I think that's really important, because a lot of noise in your head can be from people who you don't know who they are, you don't know what they're taking, you don't know anything about them. So that's really also important, to be very selective about the information that you're absorbing.
Yeah, was spot on.
It's like any information, isn't it? Just make sure that you understand it and you know where it's coming from, because there's a lot of people out there, even other doctors. I mean, I don't do any paid work with any pharmaceutical companies. It's really important that people know that. So I do not have a hidden agenda. I don't have anyone who's affecting my income or my organization's income by pharma. But people often do. So you just have to be really careful, like work out who they work for, what they're doing, who they're part of, because that can often, not always, but it can change the dialogue a bit.
Yeah, good point. So either alongside HRT or separate to it, what else can women do to help with hormones, whether that's diet
and that's really important. So, because I didn't really answer your question before, people, an alternative. And I don't think it should be, we see it as HRT or something else. HRT is part of treatment. So if people take HRT or not, we need to also look at everything else. So we need to look at what other drugs are we taking, so either prescribed drugs or over-the-counter drugs, because they can interfere with how we're feeling. There's a lot of menopause-related marketed supplements products, but often there's no evidence behind them. They can be expensive. We don't even know what they do. Just because they're so-called natural doesn't mean that they're safe. And then we should be looking at our nutrition. And we do know that, if we eat better, we will feel better, but it can take a little while. So rather than just changing your diet overnight, start to add in some more fruit, some more vegetables, some not processed foods, reduce sugar. Think about alcohol. Think also about what people are drinking as well, because a lot of people's nutrition is good, but then they're having cans of drink or bottles of coloured whatever. And actually, we don't need these products. They're basically chemicals we're just putting in our body, really, aren't we? So really important. And then looking at our exercise. And, as women, when we become menopausal, we have an increased incidence of sarcopenia, which is loss of muscle mass, and also increased incidence, I've already said, of osteoporosis. So anything that's going to build our muscles, improve our bone strength, but more importantly, help our mind. We know that exercise is really good when we exercise, but finding the right type of exercise for you. Mindfulness is really important for us too. And, I meditate quite a lot, which is really important just to clear my brain. And the way we sleep can, there's all those things is really important, because it's setting ourselves up for our future health as well as not, just our menopause. So, lifestyle shouldn't just be because we're menopausal. We should be doing it anyway, but it will improve the way our menopause is, if that makes sense.
Yeah, no, it does. It does. I think we dismiss those quote unquote simple things too easily. So I guess I just want to change age now. So I'm a child and adolescent psychotherapist, so I see anyone from 4 up to 25. But a lot of teenagers, young teenagers, and obviously hormones are raging for both boys and girls in that time, and we can see OCD come on in a big way in that period. I guess just anything you want to say around that time period and hormones.
It's really, really important, because the chaos of hormones then is very similar actually to the chaos of hormones in the perimenopause. And it's normalized a lot in conversation, but I don't think it is always normal. For some people, like my 14-year-old daughter was a bit stroppy the other day, then her period came the next day and we had a bit of a laugh, but she's quite level-headed, she's fine. But actually my 19-year-old has struggled a lot with her hormones. And she's tried different contraceptive pills, which one of them wasn't right for her at all. And my oldest daughter, who's 21, I've done a podcast with her, has quite bad PMS, actually. And it's only 3 days a month. And I realised it more in lockdown. But actually, she said, Mummy, it's not those 3 days. The 3 days is when I have symptoms. But the other days, I'm thinking about those symptoms. And I was thinking about how low I was and how really dark some of my thoughts were. And that's really tormented me. And so she's been very fortunate. She has hormonal treatment, actually, which has meant that her hormone levels are the same every day. And so she doesn't get fluctuation. She no longer has PMS. And it has been absolutely transformational for her. But someone recently, one of our relatives said, oh, it's only about PMS. It's only 3 days a month. That's just normal. That's what girls have to put up with. But actually, we need to get out of that conversation saying, oh, never mind, it's just hormones, you'll grow out of it. Well, actually, if you're a 15-year-old adolescent who's finding it really difficult to go to school, or you're finding life really hard, then waiting for 6 months is a long time, let alone till your mid-20s and your hormones have settled. And that's where I think we need to really do more research, but we need to look at the types of contraception we're using, the type of hormones we're using, and knowing that hormones are so safe, and using small doses just to help those 3 days a month is not the worst thing in the world to do. So I really feel very strongly for people who are adolescents and struggling with their hormones, because we can't just normalize the conversation because it's not normal for them.
No, and 3 days is still a hefty chunk of someone's month.
Of course it is.
Yeah, absolutely. So, now again, I want to change genders just for one question, just out of curiosity. As a man myself, we obviously don't go through the perimenopause or menopause, but I believe there are certain changes in hormones for men at the similar sort of age.
Yeah, so testosterone deficiency in men is common, and it's more common actually than we think. It affects at least a third of men and probably more. I've done quite a lot of work with the British Society of Sexual Medicine for many years, and there's very similar parallels actually. When women have low testosterone, or when men have low testosterone, often they have low mood, reduced energy, poor concentration, they can put on weight, they find it harder to exercise, they can have reduced libido as well. And often people go, it's just because I'm older. But actually, testosterone in men is almost easier because you can do a blood test. It has to be a morning test before 10 a.m. Usually do 2 samples. And if it's low, then people can often try testosterone. And men who use testosterone often find, like women do, that their mood, energy, concentration, stamina improves. I'm not aware, I might be wrong, but I'm not aware of any good quality research looking at OCD and testosterone in men. Or actually, well, like I said before, I'm really interested in the role of progesterone in men with OCD, because I think progesterone is a very calming hormone when you get the right dose right. And I see a lot of women who have been transformed with just progesterone on its own. And a lot of men get quite freaked thinking that they've got progesterone and estrogen, but they have, So our testosterone is actually made from progesterone, which is quite interesting as well. So you have to have progesterone to get testosterone. So there definitely needs more research across. We can't be thinking it's just a gender thing or just a one hormone thing. So the more we can do in this area, and I think the people that are affected really want the research. It's just the people that control research aren't so interested.
Yeah, well, there needs to be money to be made, right, from the research to get funded. And
that's the problem with any hormonal research. It's so cheap. Hormones are very cheap. There's no big pharma around it. But there are other ways of getting money and grants, and we need to make sure these are explored properly too.
Yeah, true. Good point. And then lastly, just anything else you wish you could have said on this topic today?
I think the most important thing is for people not to feel that they've been cheated by a healthcare professional or by information that they've given. You have to be really strong, actually, I think, to try and get the right help, advice, support, and treatments. So make sure you make a decision that's right for you. It's really easy for other people to tell you what you should and shouldn't be doing. But actually, I think the most important thing is for people as individuals to just have a bit of time to themselves and reflect and think, which bit is right for me? And also knowing any decision you make, whether to take treatment or not take treatment, is irreversible. So what you decide today, you can change your mind tomorrow. And that doesn't matter as well. And that's important.
Yeah, good point. Good point. Thank you so much for coming on. I never thought I would find women's hormones so interesting. So thank you.
Well, I'm pleased that I've opened your mind to it. So, and thanks ever so much for inviting me. It's been great.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/the OCD Stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.